Hello everyone. Now I will discuss question of psychiatry. So we got a 75-year-old lady who is being evaluated for agitation and confusion while hospitalized. She was admitted 4 days ago due to fever, productive cough, and shortness of breath. Maybe she was having some respiratory problem. The patient was diagnosed with community acquired pneumonia. The symptoms are going with the diagnosis, and her condition has improved with antibiotic. However, for the last 2 days, she had episodes of confusion and agitations, especially during the evening and night. The patient's medical history include hypertension, osteoarthritis, mild dementia. She lives with her husband in a senior living facility and is able to perform her activity of daily life with minimal assistance. Her temperature is normal, BP is normal, pulse normal, and even oxygen saturation on room here is normal. Now the patient recognizes her husband at the bedside but is not oriented to time or location. During the examination, she repeatedly tries to climb out of bed but calms when reoriented. The patient follows simple instruction and has no focal weakness or sensory loss. The moist mucous membrane and crackles in the right bases are there. Lab shows improving leukocytosis with normal electrolyte. TLC count is coming to normal side. Which of the following is the most helpful in managing the patient current condition? Well, these are the 5 options we have to do for this patient. In this, the right answer is reduce nighttime noise and disturbance. Why this? Why not others? So first we learn what the problem is. This is a hospitalized patient. She is an elderly lady and she has delirium. With why she had delirium? This is an acute onset agitation, confusion associated with disorientation, increased motor activity, trying to climb out of bed frequently, especially in the evening. Now, something regarding delirium. This usually is associated with some medical illness. And point to be noted, the problem in the evening is more. That point should be noted very carefully. It has a special meaning also. So we talk about delirium is most commonly seen in those who are hospitalized patients. And most often they are elderly, like our patient is also around elderly lady there. Very common in underlying dementia. Our patient has mild dementia or previous stroke, which can reduce cognitive reserves. Or it may be associated with some other medical illness also. So, medical illness or previous dementia or previous stroke, and it's an acute onset problem. But now, why this happened? What is the basic reason? Increased oxidative stress, maybe neuroinflammatory mediators and impaired neurotransmitter functioning. That is a little bit about pathogenesis of this condition, why this happened. Now, what are the special features by which you can really click that we are dealing with delirium? It occurs quickly over hours to days. In our case also, it is all matter of 2-3 days only. She was hospitalized for pneumonia, given antibiotic, and 2 days later she had the problem. Manifests with some changing in severity. Patient is better in the morning and worse in the evening or night. Like our case also, main problem is in the evening hour. So you can say sleep-wake changes, and the actual word they use is sundowning. The word sundowning means as the sun sets, the patient problem increases. That's a classical thing. So evening increase in the problem is one of the classical feature of delirium. So changes in level of consciousness, patient is better in the morning and worse in the evening. In a setting of acute medical illness, the diagnosis should be delirium. Delirium is reversible in majority of cases. That's a good point. It's a short problem. You treat the basic cause, and majority of time they recover very nicely. So management include identifying and treating the underlying inciting factor like pneumonia with antibiotic, like in this case also. Once we treat the pneumonia, the patient will improve. Then we have certain non-pharmacological technique also, which are again much more important than the medical treatment. Of course, medical treatment is important, but these are also very important. Reduction of nighttime noise and disturbance. Definitely, the patient is sleeping. If there is no noise, no disturbance, is bound to calm down the patient. Frequent verbal orientation. Keep on talking to patient again and again when the patient is awake. That is really going to help the patient a lot. Reassurance. Tell the patient that the patient will be all right. Interaction with a family member also, you have to really tell as a physician or as a medical person, you have to tell the family member, nothing, worry about it, is this happen? And talking to family member. And finally, the presence of a trained sitter at the bedside is the best, if possible. Now let's look into other options. Encourage bed rest to minimize fall. Using soft bilateral physical restraint and encouraging bed rest in the attempt to minimize fall can worsen agitation. Don't forget, patient is already agitated, so it will be just like adding fuel to the fire. It results in impaired mobility and pressure ulcers. Definitely, when you tie the patient to the bed whole day, definitely going to cause pressure ulceration. These measures are used only when non-pharmacological measures are ineffective. Patient remain a significant risk of themselves. They can cause injury to themselves or to other or other despite use of medication, antipsychotic. Then they are the last resort to be done. They are never the first line treatment. Okay. Initiate low dose benzodiazepine therapy is the next option. Low dose like lorazepam, medication with a rapid onset of action can be used to control agitation and combative behavior. However, they can have a paradoxical effect in elderly because causing disinhibition, thereby worsening the delirium. So that's why they are never the first line treatment. Again, try non-pharmacological treatment. Well, option C, limit the patient interaction with family member. It's the other way around. Already discussed in non-pharmacological treatment is talking to family member is one of the best technique to be used as a non-pharma treatment. Okay, so it can worsen delirium by disorienting them further. Most patients may improve outcome by interacting with the familiar faces. So always encourage the family member to talk to the patient so that the patient feels better. Well, the option D, provide sensory overstimulation to keep patient attentive. Providing sensory overstimulation to keep the patient attentive can worsen agitation, can lead to worsening of confusion. So, because it will not allow the patient to take proper rest. So, this is again not the right answer. The golden line to remember, delirium is a reversible disorder, very, very important, and characterized by agitation and confusion, most frequently seen in elderly or those who are having underlying dementia, usually with some associated medical illness. Okay. Like in our case, patient is suffering from pneumonia. Acute onset, fluctuating mental status changes. Morning, the patient is much better, and in the evening or night, patient is very much agitated. So you can say there is a variation of problem is from morning to evening. Disturb in attention and determining the underlying cause, avoiding unnecessary medication, treating infection and metabolic disturbance are the main treatment. Encouraging regular activity during the day while minimizing disturbance at night can help the patient recover much more quickly. Okay. Thank you very much.